We have with us Dr. Sheetal Mahuvakar. She's coming with the rescue team to red code in cataract.
And thank you for including me in this wonderful session. And sorry for coming late as I was there in the other commitment. So what I'm going to talk about is one case which I've come across, and basically there were too many irons in the fire. So this is a case which I'm going to present as a management of traumatic subluxated cataract, glaucoma, and mydriasis. So this was a 32-year-old patient who had met with a history of trauma and road traffic accident. When he presented to us after a few days, he had corneal edema. When I stained him, there was epithelial defect. There was a lot of AC reaction. His IOP was high. So what we did was we just started him on topical steroids to take care of the inflammation, anti-glaucoma drops, and he eventually healed with a central corneal opacity, for which the PTK was done after 2 or 3 months of his whole healing. The PTK video is not there. So once PTK was done, I waited for 3-4 more months, and then he still remained with a mild opacity, and his glaucoma was uncontrolled on maximum anti-glaucoma medication. He had subluxated cataract, and there was an atonic pupil. So I'll present this video now. How do I? Yeah, okay. So this is how you can see the epithelium was still little thick on that side. The epithelium was removed at the time of the surgery to have a better view. You can see that there was quite a large subluxation from, this is a surgeon's view, I sit superiorly, so there was almost from around 1 to 2 o'clock till 6 to 7 o'clock, but the subluxation was not very, very bad. So once the epithelium was removed, basically whenever I'm doing a combined surgery, I will make a scleral flap, partial thickness scleral flap, before I take over the cataract surgery. So MMC was applied for 2 minutes, and then a thorough wash was given. I don't know how to do the forward of this video in between. I need to do it. If anyone can help me with that. So whenever we are putting the MMC, make sure that you take out all the MMC balls you have applied and do the thorough irrigation. Once this half anti-glaucoma surgery trabeculectomy procedure is done, we move to the phacoemulsification. In this case, whenever there is a combined surgery, I would approach the cataract surgery or phacoemulsification from the temporal side. As you can see it out here, now the subluxation is seen pretty well on the temporal side. So can someone help me with how to forward it, because normally I can do it but not happening here.
It will not. The bar is not there.
No, the bar is not there. Yeah.
You have.
Oh god, I don't have that. Okay. So I'm sorry, it will go a little slowly.
That's okay.
So as usual, the side ports were made, the main wound was made, and now you can notice it when the rexus was going fine. Inferiorly, rexus was fine, but when you come here superiorly, I was having some struggle while doing the rexus. I needed to put little more strength. So it was like there in my mind that maybe there is some kind of a zonular weakness, maybe there is some problem over there. Luckily, the cataract was very, very soft. There were just some cortical spokes and little bit of PSC. So the hydrodelineation and hydrodissection soft was done considering the subluxation also, and I did not use any kind of phacoemulsification in this because it was a young patient, so there was no age-related nuclear sclerosis. So with the irrigation aspiration only, the lens aspiration was done, and cortical removal was done. Now here, because of the PTK, I was not worried because we were going to take care of cataract, that we would take care of the refractive error which was induced by PTK. As there was a mild subluxation which was not very bad, we put the CTR instead of the Sioni ring to give a stabilization. Also, this is a traumatic subluxation, traumatic zonular weakness, so it's not going to progress beyond this. Whatever is there, it is going to remain at this stage, unlike your normal congenital ones. The 3-piece lens was put inside. And now with this, the phacoemulsification part was taken care of. But what to do with this big, large pupil? Now we had to, after putting the IOL, we had to take care of the atonic mydriatic, traumatic mydriatic pupil. So the pupilloplasty was taken care of. So before doing the pupilloplasty, basically we need to kind of mobilize the iris. Because of the trauma, there could be a lot of fibrosis at the angle. So with the help of the forceps, microforceps, I was just trying to pull and release whatever adhesions were there in the angle, as also it gives me a good amount of tissue to repair it once you release it. So this was done 360 degree. I'm very sorry, again it's going to play a little slowly. So once this was done, this would help also in the for the glaucoma part of the thing, because if there are some kind of adhesions in the angle, it will release, and that will also help in control of the IOP. Once this was done, now there are two things which one can do. One is your fourth row pupilloplasty one can do, or such a big pupil, you can do purse string pupilloplasty. I do both in my practice. So in this case, I decided to go ahead with purse string, thinking that okay, I might give him a slightly better round pupil. So for purse string pupilloplasty, you need to have 4 openings. So there is a main wound on the temporal side. There are those phacoemulsification 2 side ports on superior and inferior side, and we met another side port on the nasal side, as you can see it. You need to use double arm 10 Oprolene suture for this, and that one arm of the needle was introduced through the nasal side port, superior in this case. And you take small bites of iris. Unfortunately, this patient had a very friable iris, so at some point whenever I was taking a bite, there was a hole which was getting created. But anyways, one cannot help with that, and you continue with it. So now once you've done one fourth of a quadrant, you take out the needle, retrieve it with the help of the 26 gauge needle, and through the same side port you introduce the same needle again inside, so and take care of the other 1/4 portion. So once you take again the similar amount of bites, this needle will now come through the main wound. So 180 degree, the inferior side of 180 degree iris bites, we have taken it, and one arm will come out of the main wound now. Although I would say after doing one or two of these things, the fourth row pupilloplasty is easier. Sometimes this gives a slightly concentric pupil than that leaves sometimes a cat kind of a pupil, cat eye kind of a pupil, but it really doesn't matter too much when you have such cases. So as you can see it with the 26 gauge needle, the same needle is now retrieved through the main wound, and 180 degree has been settled. Now the second arm of the needle, the 10 Oprolene needle, should be introduced again from the nasal side, from where we first introduced this particular thing, that is from here. If I think we don't have a pointer, from the superior in this videos, which is actually a nasal side port. So you introduce the second arm and you repeat the similar procedure. Take 1/4 bite, take it out from your other side port. Once you are done with the 1/4, introduce the same needle again through the same side port, like the superior one near the flap, and complete another half also. So this way we will complete the 360 degree of the iris, and both the needles eventually will come through the main wound.
Madam, you have to sum up.
Yeah. Okay, I'll just so basically we just tie this once it comes off, and the trabeculectomy was finished. When I did the trabeculectomy at encapsulotomy, there was a slight vitreous loss, and that explains why I was having a trouble while doing the CCC out there, and that was taken care by the local anterior vitrectomy. So this was the picture in the end after around 1 month or so. The patient's BCVA was 6.9 with some amount of refractive error. His IOP was controlled. His pupil was pretty good. Again, whenever you're doing a pupilloplasty, you have to make sure that what size of pupil you want. You should not make pinpoint pupils in such, even though that might give you a better vision. Such cases need retina evaluation. Such cases need glaucoma evaluation. So keep something around 4 to 5, which will take care of his photophobia also. Thank you so much.
Thank you, Dr. Sheetal.